Good morning to all our participants. And because of this time difference, we'll be soon starting. So as our speaker is also online, so we will get started. Seeking the blessings of His Holiness, I would like to welcome our principal, Dr. Ravindra, sir, and vice principals, Dr. Dakshani and Dr. Chandrasekhar. Our panelists, Dr. Anil Kumar, Professor, Department of Prosthodontics, and Dr. Bhagyalakshmi, Reader, Department of Orthodontics. I also welcome all my colleagues and participants who have registered today. And it gives me an immense pleasure to welcome our speaker for today, Dr. Anand Bhatt, who, in spite of his busy schedule, has agreed to give us this talk on basics of sleep disorders and its oral connections. Dr. Anand Bhatt works for Highland Clinic in Shreveport, Louisiana. He has done his fellowship in allergy and immunology and has done his fellowship in sleep medicine from Kansas City. He is a board certified internal medicine and is a fellow of the American College of Physicians. He has several awards to his credit, such as National Award for Students Committed to Professionalism, Global Health Award, Scholarship Award for elective in Workers' Health, Rural Nicaragua, Hagel Medical Spanish Scholarship for Students Committed to Hispanic Healthcare. He is also actively engaged in services to the community, such as fundraising for the AIDS victims, health missions to Texas and Mexico border. He has various publications and presentations and has traveled over 20 countries. He is well-versed in Spanish, in addition to other languages. And Dr. Anand Bhatt is also is the husband of our alumni student, Dr. Maithili, Dr. Maithili Radhakrishnan, whom we are all very familiar and very well acquainted. Many of us are not aware about how sleep influences both systemic as well as oral conditions. So that is the reason why I have called on Dr. Anand Bhatt to enlighten us on this topic, as many of us are very ignorant on the basics. And even though we know there are some connections, we are not very familiar with it. So over to you, Dr. Bhatt. We welcome you once again, and we leave it now to you to take the floor. Thank you.
We can see your slides.
So request you to go to the slideshow mode. Thank you so much. That's fine.
Okay. Okay. Hopefully you're able to see this. Okay. So I've labeled this talk "Sleep Medicine Basics for Dentists." I've included my certifications below. I'm pending my American Board of Allergy and Immunology. Hopefully I passed that exam last month, but I don't know till next month. Okay, so every medical talk I feel is the same. So you should have the same sequence of things. So you should know why something is important and why you should care. So the first thing is the burden of disease. So I have some American and then a few Indian statistics here. So what is the burden of this disease of sleep disorders? So millions of Americans are not getting enough sleep. That leads to decreased productivity, increased mental illness, metabolic dysfunction, and it increases the risk of hypertension and diabetes. Sleeping less than 7 hours a day is associated with increased risks of car crashes. In the United States, most people have to drive to work. Sleeping less than 4 hours is associated with a single car crash increase by 3.4 times, and 20% of car crashes are associated with drowsy driving. So very, very dangerous. Now, there are longitudinal data in the United States looking at sleep. I don't know if anyone has done this in India going into the past, but we do know in 1985, the average American adult slept 7 hours and 24 minutes. And now in 2012, we have the average American sleeping 7 hours and 11 minutes. So we can see that the average amount of sleep is decreasing in the United States. In 1985, 22.3% of adults slept less than 6 hours. In 2012, that became 29.2% of adults slept than 6 hours. So we can see that the people with very low amounts of sleep is going up as well. The average and the poor sleepers are increasing as well. I don't have the original citation for this, but in India Express, they had an article about Fitbit data. There were 18 nations and India was one of them. Some of them are in the Asia Pacific region like Singapore and Japan and Australia. Then some developed countries like the United States and Germany, and then Peru, which is in Latin America. So we can see a diversity of countries. Obviously, not everyone uses a Fitbit in India. Probably a very, very small number of people have Fitbits in India. But based on this data, Indians get the least amount of sleep besides the Japanese. So Indians are sleeping only 7 hours and 1 minute. So if we go back, that is significantly worse than the average American in 1985 or 2012. And in terms of activity, because the Fitbit does record how many steps people do, Indians are the least active out of all 18 countries, only walking 6,533 steps and only 32 minutes of activity. Assuming that the average person who can afford a Fitbit would be someone in an urban area, I'm not surprised that people who would be able to afford a Fitbit in India don't walk much, because it is virtually impossible to have a pleasant walk in urban India from my experiences. So what is the history of sleep medicine? Why is it not very well known? Well, the reason it's not well known, not just in India, but in the United States as well, is because it is a relatively recent field. If you can imagine, in my original field of internal medicine, William Osler lived and died a long time ago, and he's considered the founder of internal medicine. The founder of sleep medicine, Dr. Dement, I actually met him at a sleep conference about 3 years ago. He just passed away a year or two ago. So we're talking about a field where the founder of the field only very recently passed away, and his followers, acolytes, and that generation is still alive. So we're talking about a much, much younger field, which is new. So to give you an idea of how sleep medicine sort of began, it starts at the intersection of neurology, psychiatry, and pulmonary. So the original idea of where and how does the brain function and how does it link to sleep goes back to roughly 1917. There was a disease which appeared and disappeared, which was called von Economo's encephalitis. So there was a disease which nobody knows the cause and why it came and why it disappeared. It was called encephalitis lethargica, and it had chronic sleepiness. Now, this disease was causing damage to the reticular activating system in the brainstem. This is the first time they were able to associate a specific part of the brain to a specific sleep disorder. The neurologist von Economo discovered these lesions in the brain that led to chronic sleepiness. He did it via autopsies. He published it in 1917. Basically, nothing happened on this topic for many decades. So if we go, and look at some of the highlights of sleep medicine, we see that narcolepsy was discovered by a French neurologist in 1880, and he separated narcolepsy from epilepsy. In 1937, Loomis and colleagues documented their characteristics on an electroencephalogram, an EEG, and determined that there was a phase of sleep called the non-REM sleep, which is non-rapid eye movement sleep. In 1953, I believe the research involved dogs. Rapid eye movement sleep was discovered by Dement and Kleitman. And in 1957, Dement and Kleitman proposed a new classification of sleep with different stages of non-REM sleep. In 1964, Stanford University established a narcolepsy center. In 1966, researchers in Europe described the clinical entity of sleep apnea syndrome. In 1978, Remmers documented the relationship between airway pressure and EMG activity, the pathophysiology of upper airway prolapse. And then in 1981, CPAP was demonstrated to prevent upper airway collapse and normalize nocturnal sleep in those with sleep apnea. And in 1993, the first epidemiological report was published showing that 2 to 4% of middle-aged women and men were diagnosed to have obstructive sleep apnea. So again, this talk is about the basics. So we'll talk about the basics of the sleep stages. So this is very little taught in the US. It's taught, but in India, I'm not sure in the dental and medical curriculum how much it is. But the stages of sleep are being awake. Obviously, all of us are awake, hopefully. We have the 3 non-REM stages of sleep, which are stage 1, 2, and 3, or N1, N2, and N3. These are non-rapid eye movement stages of sleep. These are what we have when we first go to sleep is the non-REM stages of sleep. And we do not have rapid eye movement, which is when our eyes will fluctuate rapidly, and we enter a basically temporary paralysis when we have REM sleep. Now, when do we dream? It's during REM sleep, which is a certain stage of sleep where the brain is as active as being awake, but you are asleep. So that's REM sleep. And then the other 3 stages are non-REM sleep. Now, deep sleep or slow wave sleep is seen in stage N3. This is very common in the youth, adolescents, and this is very important because this is the stage of sleep where recovery sleep occurs and growth hormone is secreted. That's why it's important for children to sleep when they're young, because that's when the growth hormones are released in the deep sleep. So what's the pattern of sleep? Well, the pattern is you start with being awake, and then you will fall down the stages into stage 1, then stage 2, then you go to stage 3, which should be the longest amount, especially in our younger people. And then REM sleep is occurring here. So we have cycles, which will be 60 to 90 minutes, where we go from awake to stage 3 to REM sleep, then again to stage 3, then back to REM sleep, then down to stage 3 again, and then to REM, and then REM again. So that's the sleep cycle as it occurs. There's a tendency for there to be more non-REM sleep in the beginning of this night and more REM sleep at the end of the night. That's why we often remember our dreams, because it's at the end of our sleep cycle, closer to when we wake up. When we are not sleeping enough, which apparently most people in India are not sleeping properly or long enough, we have catch-up sleep. Catch-up sleep will disproportionately be more N3 sleep on the first night of catch-up. So what percentages are we in certain sleep stages? Well, REM sleep should be about 20 to 25% of your sleep. Infants have 50% of their sleep in REM. That's why children are always waking up and at random times when they're infants. It's because their sleep stages are not properly defined, and they have incomplete sleep cycles because the different stages of sleep have not been developed in their brain yet, but they spend 50% of their time in REM. Children have very high levels of stage 3 sleep, and growth hormone is secreted at that time. That's why it's important for children to sleep when they're young. Sleep efficiency does decrease. Sleep efficiency means the percentage of time you're in bed which you're asleep. Sleep efficiency does decrease as we get older, and there tends to be a little bit less REM sleep in older people compared to younger adults. Now, we will start with a case. It's not my case. It's not an original case. This is from the New England Journal of Medicine from about 3 years ago. So we have a 58-year-old woman with fatigue and sleepiness. She is sleeping 7 to 8 hours a night. She wakes up unrefreshed. She's been told by her husband that she snores. She wakes up nightly to urinate and typically falls promptly back to sleep. And recently, she has noticed sleepiness when she's driving home from work. Her medical history includes obesity, hypertension, and type 2 diabetes. Her body mass index is 35. She has a large tongue partially obscuring the soft palate. I guess audience can answer, what do you think this disease is? Does anyone want to guess from the audience or from the panel? Okay. Okay. Well, I'll just answer the question. Oh, wait, is there somebody in the chat? Obstructive sleep apnea. Yes, correct. Yes, I see here in the chat. Great. Yes. So this is obstructive sleep apnea. How would we evaluate and treat this patient? Well, that's where we're going to get to next. So obstructive sleep apnea syndrome is characterized by episodic sleep stage dependent collapse of the upper airway, resulting in periodic reduction or cessation in ventilation with consequent hypoxia, hypercapnias, or arousals from sleep. By convention, the apnea-hypopnea index has been used to quantify obstructive sleep apnea. Sleep disordered breathing is the broader term for these phenomena. And there's a scoring manual which was developed by the American Academy of Sleep Medicine to standardize these criteria in human research. Although many sleep labs have adopted these recommendations, there are some diagnostic variabilities. According to this document, an apnea involves complete upper airway collapse and almost complete cessation of airflow, whereas a hypopnea, it would be partial, around 50%. So the symptoms of sleep apnea, we have snoring, we have daytime sleepiness, we have choking or gasping at night, we have night sweats, there's neurocognitive impairment. When you have poor sleep, you do get very argumentative and you don't listen and you misperceive things. You can get heartburn, you can get morning headaches, maintenance insomnia, and for the men, erectile dysfunction is an issue, and nocturia, that also can be an issue. So how do we measure and quantify obstructive sleep apnea? We use a sleep study. There are two types of sleep studies. There are sleep studies in the lab, and there's sleep studies which are performed at home. So when I did sleep medicine, I did it in Kansas City, as indicated. In Kansas City, it is a major for American city. It's about 1 million to 2 million people. However, there are no major cities around it for several hours, 3 to 4 hours. So we had a lot of rural patients come in, and it was difficult for them to drive 2 to 3 hours to pick up something and drive back to return it. So they had home sleep tests as well. Well, what's the difference? Well, you have a sleep study in the lab. Well, you have to physically go to the lab. You have to sleep at the sleep lab, and they will do an EEG on you while you're sleeping. The home sleep tests don't have an EEG. The lab is going to be accredited, hopefully. I don't know how the accreditation works in India. I know there is some sort of accreditation process I've seen on the internet. The home sleep tests can be mailed back, which is what a lot of our patients did. We would mail it to them and mail it back depending on the patient. But that was something that could be done for our rural patients. The lab has video monitoring. The home sleep test has no video monitoring. And for concurrent, movement disorders like neurological disorders, it's better to do in the lab. And severe pulmonary disorders like COPD and hypoxia should be done in the sleep lab. The home sleep test has the respiratory channels, which can measure sleep apnea and apneas and hypopneas, but that the lab can do. But the main issue is there's no video and there's no EEG on the home sleep test. Hypopneas are associated with partial collapse of the upper airway. They also exist on the pathological continuum with apneas and may be important as well. They may make up the majority of disordered breathing. So we put all the apneas and the hypopneas that are measured in an hour and make it into an apnea-hypopnea index, and that measures the frequency of disordered breathing events. But this is used to quantify the severity of sleep apnea. So the apnea-hypopnea rate, how many events in an hour, is how we scale or quantify how severe someone's sleep apnea is. So that's in there, but I don't know. So basically, there's mild sleep apnea would be 5 to 15 events in an hour. Moderate would be 15 to 30, and greater than 30 would be considered severe sleep apnea. So OSA is a systemic pathophysiological entity, has many comorbidities such as hypertension, stroke, and coronary ischemia. This may exist in 3 to 7% of people. The risk factors exist that contribute to this are excessive body weight, alcohol, smoking, nasal congestion, and menopause. Sleep apnea is less common in women until they have menopause, then the rate becomes more similar to men. It has been recognized that men have greater vulnerability than women in developing obstructive sleep apnea. Now, there's going to be a bunch of dental words. I don't know these words very well, so I will, this slide it was prepared by my wife, I think. Several soft and hard tissue factors can alter the mechanical properties of the upper airway and increase its propensity to collapse during sleep. So retrognathia, tonsillar hypertrophy, enlarged tongue or soft palate, an inferior position hyoid bone, maxillary and mandibular retroposition, and decreased posterior airway space can narrow the upper airway dimensions and promote the occurrence of apneas and hypopneas during sleep. Obstructive sleep apnea may manifest in many different ways. It can subtly arise into daily life. It may not be recognized by the patient and providers, and it can lead to profound sleepiness, snoring, witness apneas, and other classic, more recognizable symptoms. Important question you usually ask is, who is their bed partner, husband or wife? And you ask them, how long have you been married? How long have you been in the same bedroom? Did you snore when you first were married, or did that start afterwards? That will help give you an idea of how long this has been going on, because people may not notice until years later. Symptom severity often, then it's also important to ask their weight when they first got married or before this happened versus now. Weights change, and as your weight gradually grows up, you may not realize that this is an issue. Symptom severity often progresses over years, leading to delayed diagnosis and allowing time for the disease to adversely affect health. Even with increasing awareness of serious adverse consequences of untreated sleep apnea, of patient outcomes and healthcare utilization, epidemiologic studies suggest that OSA is underdiagnosed. Probably 90% of people are not diagnosed. So why does this diagnosing this matter to the patient? To give a dental equivalent, we know that gingivitis can increase the risk of heart disease by 2 to 3 times, while obstructive sleep apnea can increase the risk of stroke, hypertension, cardiac arrhythmias, and heart disease. So what are our physical exam findings? We have obesity, enlarged neck circumference, crowded upper airway. We have hypertension, accentuated P2 heart sounds, retrognathia, nasal obstruction, decreased oxygen saturation. And if they have CHF, you can have the S3 heart sound and lower extremity edema. So the diagnosis of OSA can be made on history, examination, polysomnography, or the different other sort of testing. An attended nocturnal polysomnogram, which requires an overnight stay in a sleep facility, is a standard diagnostic modality in determining if a patient has OSA. As I indicated before, the AHI index has 3 categories: mild, moderate, and severe. 5 to 15 events per hour for mild sleep apnea, 15 to 30 per hour for moderate sleep apnea, and greater than 30 for severe sleep apnea. So the question is, what can I do? So I don't like it when people present things and they have no idea what you're supposed to do. It's not very useful. So I decided to provide you with some examples of things you can do in your practice or even for yourself and friends and family. So I went to the dentist 2 weeks ago and they did the stop bang questionnaire when I was filling out my paperwork in the waiting room. So the stop bang score, if you're not aware of it, this is done in dental clinics, apparently even here in Shreveport. And the stop stands for, do you snore? Are you tired? Have you been observed to stop breathing? Do you have high blood pressure? And the bang is BMI greater than 35, age greater than 50, neck circumference greater than 40 centimeters, and being male. If you have a score of 3, that makes you higher risk for having obstructive sleep apnea. So just a very quick, easy screen anyone can perform in healthcare, medical or dental or nursing or whoever, to screen the patients for OSA. Another one linked to sleep apnea, but not necessarily only to sleep apnea, a very convenient way to measure your sleepiness, your patient's sleepiness, or anyone's sleepiness that you're concerned about, is to use the Epworth Sleepiness Scale. The Epworth Sleepiness Scale is is a questionnaire from Australia from 1991, and it asks you to score your sleepiness in certain different scenarios. As a passenger in the car, sitting inactive in a public place, sitting and reading, watching TV, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after a lunch without alcohol, and in a car while stop for a few minutes in traffic. So you can quantify this, and the scores are 0 to 5 would be normal, 6 to 10 would kind of be high end of normal, then mild sleepiness would be 11 to 12, moderate would be 13 to 15, and anything greater than 16 would be severe excessive daytime sleepiness. Looks like I got a question in the chat. How is OSA different from central sleep apnea? What is the treatment, and is it similar for both? The answer for that is OSA is either peripheral or central sleep apnea. Central sleep apnea is more neurologic. It is more common in people with lower body mass index. Peripheral sleep apnea is more your classical overweight. If I'm not mistaken, I think in Southeast Asia, I think in Cambodia, central sleep apnea is seen. Also, it's seen in heart failure and uncontrolled heart failure. So they are different. They're more neurologic in origin, and sometimes you may have to use a different machine than the standard CPAP. But that's they are different, and the home sleep test the in-lab sleep test would be able to help you diagnose between the two, whether they're central or peripheral. Okay, what is the role for dentistry? Oral appliances, again, this would be more better discussed by dental professionals, unlike myself, but at least what I was able to see in Kansas was that they have oral appliances which can be used, and they can help manage mild to moderate sleep apnea. There are patients who do not tolerate CPAP, and patients may benefit from using a oral appliance, which can be created by a dentist. The American Academy of Sleep Medicine has recommended oral appliances for use for patients with primary snoring and mild to moderate obstructive sleep apnea. This can also reduce the AHI to normal in 50 to 60% of patients. The role of the dentist as it relates to repositioning the mandible to enhance growth in cases of mandibular retrusion dates back to the 1800s when Kingsley described a maxillary appliance that was designed to advance the lower jaw. The oral devices, again, this slide is definitely from my wife. Oral devices are basically thermoplastic materials with retainers and supports, and are usually custom made. That's a very important thing, that they're custom made and evaluated by a dentist, and not something very standard that comes in the mail and is not assessed and adjusted. There are many different types of appliances and devices that can be used, but I think that would be best discussed by someone from the dental field. This is what obstructive sleep apnea looks like in the mouth at this cutaway, and then you can see how the oral appliance is reducing the tongue from falling back and causing the obstructive sleep apnea. Oral devices, the physiology, the first well-recognized appliance to manage snoring and sleep apnea was the tongue retaining device, which was created by a psychiatrist. The idea was to bring the tongue forward so it would not collapse back in the airway. By doing so, the airway would be expanded or opened, allowing air to pass with less resistance, and thus snoring would be prevented. There is a need for dental sleep medicine curriculum. The demand for oral appliances to treat sleep-related breathing disorders has increased and will continue to increase. The only practitioners considered to be qualified to treat obstructive sleep apnea and mandibular advanced devices are diplomates of the American Board of Sleep Dentistry, or others who have undertaken a comprehensive training in sleep medicine and or sleep-related breathing disorders. So I live in the state of Louisiana currently. I did try to look how many sleep dentists are diplomates in this state. The state has like 4.6 million people. there was only 5 in the entire state. The closest one to me was an hour and a half away. So not very many in this state. So very, very underserved even in the US. The American Academy of Sleep Medicine has published clinical guidelines on standards and options to standardize the clinical use of oral appliances in the treatment of snoring in OSA. I have some YouTube videos. If this video is going to be, if the slide will be shared by the audience, they can click on this. It's a talk from the president from about 4 years ago of the American Academy of Sleep Dentistry, and then the AADSM website if you want to learn more. There was a survey looking at what is because I'm speaking to a dental school, it's important to know what innovations the curriculum and the dental school can do. Well, there was a survey where 58 schools were surveyed to see how much sleep medicine, sleep dentistry was taught in dental schools in the United States. Only 49 responded to the survey, but 75% of dental schools did report some teaching in sleep medicine. 24.5% did not teach any sleep medicine. About 26 schools taught 1 to 3 hours, which was the most common. 5 schools taught 4 to 6 hours, and 3 schools taught 7 to 10 hours, and 3 schools taught more than 10 hours in sleep disorders. Is there a periodontitis link to OSA? I'm not sure about that. That's a interesting question. I've not looked into the relation of gum disease and OSA. That may be true, but I'm not sure. While this study shows that there's an increase in the number of dental schools teaching sleep medicine, there was also an increase in the average amount of hours of sleep medicine. The number of individuals with sleep problems in the US is far greater than the number of healthcare providers who can identify and manage this, and education continues to be inadequate. Clinical trials on combined oral appliances and positive airway pressure therapies are needed. And there's a need for a formal residency program. Yes, the American Board of Sleep Dental Medicine has an exam, but there's no sort of training program for this. So there's just an exam that you take and you go to some sort of classes or something, but there's no residencies per se, from what I understand in the US. In India, I did find that there is an Indian Sleep Disorders Association, and it does have a dental chapter. How active it is, I couldn't tell. The Indian Sleep Disorders Association canceled their 2020 meeting due to COVID-19. I don't know if they've had a meeting since. It doesn't look like they have had one, but there is a dental chapter within the ISDA. So that might be an avenue to approach sleep medicine in India and sleep disorders for the dental profession. Then finally, I do want to recommend a book that would be could be read by physicians, patients, families, and friends. This is a British PhD who works at Stanford University. He's a sleep researcher. He's written an amazing book about why we sleep, how we sleep, why is it important. Definitely a great book. I learned things in this book that was not in my sleep fellowship or in my sleep board exam, and tells you a lot about the history of sleep medicine and how the original researchers in the 1950s, 60s, and 70s came up with many of the innovations, including people who had to sleep in a cave to figure out the rhythm of the circadian rhythm by sleeping in a cave that had no light. So really, really fascinating book. I recommend anyone medical or dental or just very interested in things to read this book. So that's all I have for now. We can go on to the rest of the program.
Thank you very much, Dr. Anand, for enlightening us on the basics of sleep. And you have gone through all the statistics, history, and how about sleep apnea and what we should be aware of as dentists, and what are the different methods of diagnosing it. So yes, and I think you have answered many questions that were in the chat box. I'll ask Dr. Swati if there is any more questions that are there in the chat box.
There is one more. Does sleep bruxism has its effect on periodontium, or does it aggravate the periodontitis?
Yeah. Can you use the mic and just, yeah.
Hello, sir. There's a question.
Won't work yet. Good.
Can you use it? Okay.
Yeah. Sir, there's one question.
I
Mobility.
think it's muted right now.
Yeah.
I don't know if bruxism has an effect on it does definitely damage the teeth, but I don't know enough about teeth to tell you what the damage is, but I do know that it will damage the teeth. I do also know that oral appliances do have some controversy in recent research, and there may be other things that are being recommended now.
I know Dr. Selva Kumar has done a lot on sleep medicine. I think he has done some degree on that, and he's quite interested in this subject because we have many times spoken on this. And yes, being a medical person, it must have been a little difficult to come into our field and understand what we require, but still you have done a good job of at least letting us know what are the basics. And coming to question, like I would like to ask my panelist, Dr. Bhagya Lakshmi, who has started a clinic in our main hospital, the Breathe Healthy Clinic, in collaboration with pediatrics department. So I will hand over to Dr. Bhagya Lakshmi. She'll put in a few words about what's going on and how it is connected and how important it is to detect this in children before they progress into the adult stage, where they can have a lot of problems due to these congenital defects. So I'll hand over to Dr. Bhagya Lakshmi.
Yeah. Thank you, ma'am. And very good morning to all the delegates and panelists present. I'm so sorry, we didn't realize that. Yeah, again, very good morning to everybody. And thank you, ma'am, for this opportunity. Well, breathing is the first function when we arrive in this world. And but yet, it's important to stay alive, not just to stay alive, but to stay alive and healthy. So though it is so important, and for day to day and night to night, breathing is so important, but most of us don't know the importance of correct breathing. So there is what is called as mouth breathing. Mouth breathing is a chronic breathing disorder, and mouth breathing is a red flag, and it is a sign of sleep disordered breathing. So with this context, we started a special clinic called Breathe Healthy at JSS Hospital, Mysuru. Breathe Healthy is a special clinic which comprises of an interprofessional healthcare management team comprising of orthodontist, ENT surgeon, and a pediatrician. So at Breathe Healthy, what we do is all these three healthcare professionals, we come together to learn with, from, and about each other. Now, sleep disorder is one such health disorder which cannot be managed by a single health professional. Neither it can be managed by working at silos. So this is exactly what we do at Breathe Healthy. For all the children who have sleep-related disorders, all the three healthcare professionals, we come together and we try to do a co-diagnosis and co-treatment planning. We do not believe in referring the patient from one consultation room to another. Neither we want to refer the patient from one hospital building to another. So working as an orthodontist, working with an ENT surgeon and a pediatrician, I'm able to make them aware about the risk factors and the consequences of sleep-related disorders in the mouth, be it enlarged tonsils, be it constricted upper arch, be it a retrognathing mandible, or be it a hypotonic lips. So this is what we are doing, working together. And I'm also getting a lot of opportunity to learn from a pulmonologist, from an ENT surgeon, and a pediatrician related to sleep-related disorders. So doing orthodontics in children with sleep-related disorder is very important because in children, the bone structure is very malleable. It's very soft. So when we do orthodontics, it helps in opening up of the airway. So it helps. It is not about the teeth. It's about the patency of the upper airway. So this is brief about the Breathe Healthy. So my also I want to add a note here that American Association of Orthodontic has suggested that treating underlying dental or an orthopedic ailment will help and not cause or aggravate OSA. So my final word would be dentist and dentistry play a significant contribution in diagnosing sleep-related disorders. We can arrive at a co-diagnosis and co-treatment planning working with a sleep specialist. Also, the sleep-related disorder screening should become a routine part in dental screening. And for that to happen, as our speaker mentioned, we need to incorporate in our case histories certain information about sleep-related disorders and sleep quality of the patient. Like we can use validated questionnaires, like how Dr. Anil Bhatt mentioned, be it Epworth's sleepiness bank questionnaire. So these things should get incorporated in our case history formats. Also, dental sleep medicine education program should be developed and should be provided both at the UG and PG level. It should get into our curriculum. So my request to all the delegates and the participants who represent membership in various board of studies, curriculum committee to please take up this initiative. And my final word to the organizing committee, I congratulate them for hosting a webinar on such an important topic. Dental sleep medicine is an emerging area in dentistry, and I wish that this webinar will be an initiative to start sleep-related breathing disorder wellness program at JSS Dental College and Hospital. Thank you.
Unmute. Yes, there was a question related to bruxism. And yes, this bruxism, yes, it is seen in sleep disorders. And you find most commonly TMJ, also TMJ disorders due to the sleep disturbance. And in this aspect, we find that the prosthodontist also plays a role in treating such cases. So I will ask Dr. Anil Kumar to say a few words.
Good morning, everyone. Dr. Anand, I think we should say good evening for you. Anyway, this sleep apnea since years, maybe 2000, at the beginning of 2000 itself, we tried to present a poster in a conference, and of course, RPG got the award and all that. But there are some devices. These devices, what they do is basically they reposition the mandible and keep the air pathway patent. Beyond that, actually, nothing much is being done. And we tried giving a few processes, but not very successful in it. I think a lot of research is required in this. We should think of it in 360 degrees, bring in all other departments, and then only do. And as Bhagya has mentioned, deep palate and collapsed arch are one of the main things which we can identify in a kid. And at that stage, if it is taken care of, then it will be more easier than handling it in an adult. Because what happens is, a senior citizen who has lost many teeth, the tongue itself will become wide because it doesn't have any skeletal system. The wide tongue will aggravate the sleep apnea. At the same time, we can't ask that patient to wear the prosthesis in the nighttime. They have to remove it. So all these factors are there, which we don't have answers for. On the other hand, I just want to ask you one thing. In case we want to identify the sleep apnea, can we use the ECG monitor, which we call as a Holter, which is connected for 24 hours, based on the ECG pattern during sleep? Will we be able to identify if the patient is having sleep apnea?
No, there is a ECG lead in the in-lab sleep study. It's a single lead of the EKG, and it's to look if any arrhythmia is there. There are home sleep tests which use the, there's one brand, I believe it's called the Watch Pat, and it's using the arterial collapsibility to measure apneas. So there is a home sleep device which uses cardiac monitoring, but in a very unusual way. So no, but not a traditional Holter monitor will not be useful.
Okay, thank you. Thank you for the answer. And it was nice going back to the basics. Learning basics is more important before you jump into something. Thank you very much. Over to you, Dr. Sheila.
Yes, when going through the paper recently, I was astonished to know that many children nowadays suffer from hypertension. So maybe the sleep disturbance could also play a role, or maybe it's the stress. And maybe, as we were telling, that there are oral malformations that are there in the oral cavity, which can also lead to all this. And we as dentists, we should be aware that it is not only the dental problems can be due to other systemic problems. It can be due to, it could be due to sleep disturbances. And especially many people complain of headaches, TMJ pains, and they have due to stress, bruxism. And all this is, it's an eye opener for the dentists. And to be, and there are some dentists who can go to, take some course on sleep so that they will be more equipped and have a better collaboration with the medical staff, so that we can go hand in hand to prevent all these problems. And especially now we have diabetes, hypertension, all that is very much related to the sleep. So that is the reason why I felt that there's a need to bring this for us all to learn something and be able to go ahead in future. So once again, I would like to thank Dr. Anand for taking up his time, and that too, due to the time difference, I know how difficult it must be. And it's Thanksgiving time, so you must be also quite busy. So once again, thanks a lot, Dr. Anand. And I would like to thank the principal and all the higher authorities for giving me this opportunity and giving me the permission to conduct this program. I thank all my organizing committee and all the Dr. Sumuk, who has been instrumental in getting this webinar done, especially in making the certificates and brochures and for the publicity. So I would like to thank him, and I thank my panelists also for contributing to this webinar, all the participants who have been here and have patiently been listening and actively participating. So thanks everybody. And I would like to hand over the certificate of appreciation to Dr. Anand. Dr. Anand, this is our certificate of appreciation. Thanks a lot. And we hope we meet in person when you come here to India.
Yes, I haven't been since COVID-19 began, but hopefully I'll come soon.
Yeah. So we welcome you and hoping to see you. And yes, we would like to give the certificate of appreciation to the panelists, Dr. Bhagya Lakshmi and Dr. Anil Kumar.
Thank you, ma'am.
Thank you, and close. Over.
So I would like to conclude today's webinar. Thanks once again and bye.